And the topic name, the duration of the topic is 15 minutes. Please, Doctor.
Good morning, everyone. I am Dr. Chaturvedi. I will be presenting you the topic, those clarity, how to save rest and mortality. So, this is actually dosimetric evaluation of heart and left condition getting treated, and in left breast cancer patients, they have increased risk of cardiovascular events. So, the radiotherapy guidelines suggest a dose volume constraint for the whole heart. Newer trends are suggesting excessive dose to left anterior descending artery, which is LAD, endothelium, that may cause a cardiac toxicity evaluation. Can be either western or constructive. Either ways will be followed by adjuvant pulmonary radiation. However, in post-op radiation, there is increased risk of radiation-induced heart diseases, especially in the cases of left-sided breast cancer. The damage can be micro, it can be macro. To the coronary arteries. So, if it's a microangiopathy, it may cause myocardial fibrosis. If it's a macroangiopathy, it is a coronary artery disease. It is well established fact that those. So, already told microvascular diseases will be there. How? So, the pathophysiology will be like decreasing the density of the vessels within the heart, leading to chronic and microvascular diseases, larger scale. So, irradiation is accelerating or intensifying the development of care. Irradiation of distal branches of LAD. That increases the risk of the late heart disease. So, a small section of the LAD, left anterior descending artery, can lead to severe toxicity and even death, as told micro and macrovascular. So, it is crucial to minimize the dose delivery to the artery. So, for assessing the dosimetric parameters, we have concluded and then planned with IMRT plans. So, at December 22, they were given, radiation was given to the chest wall and we taking dosimetric along with B25 and mean dose of heart.
उसके बाद सीधा यहाँ पे सेशन खत्म हो गया ऐसे ही करना ठीक है
We'll be starting the show, but I would like to officially begin the show by please calling the chairpersons. Please, Dr. Poonam Gupta, ma'am, please come to the dais. Thank you so much.
And technique was used and dosimetric parameters of PDB, which include D95, D90, the mean conformity index and homogeneity index, along with B25 and mean doses of heart and LAD were calculated, dose per histogram were calculated and compared. in those 28 patients, the most common site which was seen was of upper quadrant. So it was upper quadrant. The upper quadrant was the highest site which was noted to have breast cancer, followed by this next site which was involving almost all the quadrants. Next was central, and remaining were the others. So LAD control is important because of the microangiography. So how is it control is important as well. So according to the guidelines, so these are the. So this is the axial section of the heart, actually the body, and in that we are trying to locate left anterior descending artery. So it is in between the ventricles. So here are the ventricles and these are the atrials. So in between the ventricles, directly along the ventricles. So there will be a small dot which will be appreciated, and because it is not very clearly seen, we have to just make sure the above shaded as a small dot in the sagittal section also, and I think this is a video, it's not coming. So in this section we can see how we can trace actually the whole of the vessel, the left anterior descending artery, which is lying between the two ventricles in both axial, in sagittal and caudal sections. So I'll play this slide again. Heart is actually pericardium, I have mentioned, it is less than 26 and B25 is less than 10 in heart. So it doesn't have any specific guidelines, but we'll see what minimum we can give, taking into consideration of the heart. So 4 out of 28 patients which were taken were of breast conservative surgeries, and LAD doses were obviously less compared to MRI cases because whole breast has been removed. So this was the parameters taken into consideration, the fetal volumes, B95, B90, mean conformity index and homogeneity index. It was up to mark. So B25 and mean doses of heart taken into consideration of these 28 set of patients. So the lowest we can see of this patient is 7.96. Like mean dose was going to be around less than 26. And B25 was less than 10%. So we can see that both the parameters are achieved in this case. The number 3. And the second one was patient number 16. So 16 is actually patient which was having, we can see here 16. So this one was of breast conservative surgery. This patient had also received less doses of the least, I will say, doses of radiation in the heart and LAD. So that one was of heart and this is of LAD. So LAD again you will see of the patient number 16, it is 22 which is received and B25 is less than, it's 29.15. And for this third patient which was least in heart and here it is 16.33. So why such a drastic high grade for LAD? And for heart it was 15.03. So the value was significant. B25 was 43 grade for LAD and 23.4 for heart. And the B value was significant. So why such drastic changes were there? Drastic change because LAD is an artery which we are evaluating, and that is a strip of the whole of the heart. Heart itself is a muscular organ. So the dose and the whole criteria, it is the whole heart which is received. And LAD is just a strip of that area. So the doses are obviously going to be high. It's like a point dose which we are calculating. The conclusion was dosimetric parameters of LAD also should be evaluated along with heart to see any or prevent any late cardiac toxicities.
And I welcome all of you to this land of having been in my workplace here for a very long time. And you know, so I'll be talking about an overview of model-based computational algorithms in the treatment planning system for external gene therapy. I'm Anish Srivastava, working as an associate professor and RSO in SMNC Archival. So, as Dr. Diksha was saying about the IMRT and will go this to the OARs, to the heart, I just would like to update you what kind of software that are being used in our life. So, initially,
तो समझ में भी आना चाहिए मैटर
the mathematical functions were started being used, and most of the software companies started with the mathematical functions. Initially developed by Jones and Cunningham, his team, and we also had in Courtyard, because of those days, I worked as a junior physicist and working in this TPS treatment system, PSP treatment system. So those days. Computational and radiation oncology. The idea is that here, this directly affects the dose of patient by the margin and interaction with the patient. Initially, the dose is calculated boxer by boxer wise. From sequence, it takes out the electron density of dense and the calculations. This is what is the Watson model of the patient. So we have CT simulator and we get the data in the form of mouse speed unit of each boxer, and this mouse speed unit is calculated with the argon doses, with the different atoms, with the density, electron density, and we get a conversion graph from house speed unit and electron density value. So at the starting of during the machine of CT simulator, we get conversion graph house speed unit, and in the treatment, it gets the house speed unit and calculates the electron density value. Broadly classified, the model-based dose computation systems have two. One is the content-based algorithms, second is the Monte Carlo. Content-based, and it has a point color, pencil color, and color code. So this is what is the point color. You can see this is the point. Just imagine in a water finder, this is the point and beam is coming here. So this is generating the dose distribution around this point and called point kernel. This is the pencil beam which is used in 3-dimensional CRT. And this pencil beam is nowadays it forms a pencil beam, and you can see the dose around this pencil beam. So the pencil beam is the the sum of the doses component from primary beam plus the scatter component within the water funnel. A term called karma, this is the total energy released per unit mass, and this is the product of mass attenuation coefficient, and another is to karma, this is called karma. What is the deposition of those? This is the karma implemented point spread kernel, point kernel, it forms the dose. So this is how the dose is generated in 2 times. In the penicillin algorithms, you can see this is a photon phase decreasing with the depth, and this is point kernel, and implemented with this one, it forms a penicillin. So I told you this penicillin is used in CPCRT. So you can see the graphical representation of energy difference of photon, and the penicillin those algorithms being kernel finds absorbed. So this is how the absorbed dose is generated in the system. The second one is the composition and supervision. So this is also a method of decomposition and radiation, random and secondary component. How all the beams are modeled, basically this is the point is very popular formula. This is the new is related with the Hounsfield unit, which is the applied density. So it finds out the dose and rate at any depth within the patient. This is what is called the rate tracing. So how this rate tracing takes place, you can see this is the point here, and this is getting the dose, and then when it is flipped, this is the target. When it is flipped, this is the dose is calculated along the point within the patient, taking into consideration the tissue heterogeneities. This is the low density of it, the high density of it, and ultimately these tunnels are filled to connect to those points. So this is how the dose is calculated, boxes by boxes, and you can see this is the grid and dose is calculated. This is a collapsed code algorithm which is used in another system. And content is actually subdivided. Why it is important? Why multi-column is important? Because this is the gold standard accuracy, provide the highest level of accuracy. Unlike the analytical model like penicillin or collapsed code or AAA, this Monte Carlo accounts for tissue heterogeneities, lung, bone, air, cavities, and complex. It serves as a reference model method which against which other algorithms are validated, and clinical relevance are specifically the Monte Carlo specific critical stereotactic, which has to be therapy, proton therapy, brachytherapy, where small errors the dose calculation and significantly affect the outcome. This is the AI generated. I have generated the AI and compared the dose distribution, Monte Carlo and examples of Monte Carlo is practiced in lung cancer radiotherapy, analytical algorithms often work especially tumor dose because they don't fully account for low density lung tissue. Monte Carlo simulation connect this modeling, electron scatter and photon attenuation. So my idea of showing this is to just make you aware what kind of softwares that are being used currently in our treatment planning system. You have the penicillin, you have you have Monte Carlo. Pencil was stressed, no doubt, but it is less accurate. And this is something in between, and you have the Monte Carlo. The basic problem with Monte Carlo is that it is a time-taking process. The time is the problem with Monte Carlo, whereas so this is why most of the centers is continued using pencil. So CCD, color code or is used by that time and Marriott and Monte Carlo. Everybody is coming to this Monte Carlo. Challenges, as I told you, is very slow process, no doubt about it. So because the millions and billions of archival history are taken, but if we miss certain histories, then those distribution might be there will be noise in the those distribution slightly inaccurate. So with this, thank you very much.
Sir, the algorithm is thank you.
And his lots of publications in the field of in his expertise with more than 25 manuscripts in different national and international
all the delegates who are present here right now. And thank you, Mamu sir and Puri sir for giving me this opportunity to showcase my work and to discuss about a very different topic. This is a joint work of the Legal Medicine and Traditional College Department. So today I will discuss. These are simple pictures for a city, that city and MRI. So always imaging has a very vital role in the planning of the prediction patient. So the basic thing which is the gross tumor volume, we always use the imaging methods like right now we are doing all the therapies. So the conventional method were like CT and MRI were used from the long that there is always around 10 to 20% change in the treatment of the patients which are not radiology planning. So this is the basis of the medical oncology like gross tumor volume, clinical target volume, planning target volume and internal target volume. So what is the biological tumor volume? So biological tumor volume is a measure of the total space occupied by the tumor in an organ, and you can easily calculate it with the help of the PET-CT. So with the PET-CT you can calculate biological tumor volume, and how it is helpful. Basically we can prognosticate the patient with the help of the PET-CT that what will be the future, how will be the outcome of this patient treatment, and this all is possible with the PET-CT imaging and by the calculation of the biological tumor volume. So this is the standard radiology planning mechanism. The patient will be positioned and immobilized, and volumetric data will be acquired by CT, PET-CT or MRI, whatever the imaging quantity is available and which is the best for that particular organ. Then images will be transferred to the treatment planning system. Then target volume calculation will be done, 3D modeling will be done, and treatment quality control analysis and finally treatment release. So if already there are a lot of imaging modalities are there, CT is there, MRI is there, ultrasounds are there, then what is the need of the PET-CT? So basically PET-CT is a functional imaging method. Here we are calculating PET and CT data. With the help of the PET data we can easily calculate the biological tumor volume, and it shows the functionality of that particular area, that particular tumor and those cells. And the CT is basically the anatomical imaging method. So it always gives us an add-on the CT images. Like we can see the functionality of the tumor, and also we can see the anatomy of the tumor in that organ. So there is always heterogeneity. As we all know that there is no homogeneity in a single site tumor. There is a lot of heterogeneity within the tumor. So we can easily find out like which area is hypoxic, where the new angiogenesis is going on. All these points we can pick up with the help of the molecular learning. This is the PET-CT. So the basic features which a PET-CT machine should have, it should have the flat couch top, And whiteboard scanner is especially for the breast cancer patients. Laser beam and patient alignment already wall mounted, and also it requires the respiratory gating, especially for the moving organs like lung, especially. So what is the clinical application and where we can use it easily? Now presently being used in every part of the cancer treatment, like for the head and neck cancer, thorax cancer, lung cancer, lymphoma, esophageal cancer, cervical cancer, prostate cancer. So it is being used in each and every part of our body treatment plan. So for the customer head and neck, like this is an example, we received a case from the customer unknown primary with cervical pneumonia. And the FNC and biopsy was the response customer. But the CT images were not helpful to find out the origin of the site. And patient underwent for the PET CT. So in this image you can see there was a small focus in the right lower buccal mucosa. And this is the CT image, this is the PET image. So on the CT image, due to the contrast difference, basically the contrast of the lesion and contrast of the muscle in that area was similar, so it was difficult to pick up the small lesions. But as you can see that the PET CT we can easily pick up. So this is the beauty of the PET CT, that we have the CT image as well as we have added on the PET image. So PET has a better contrast visualization. So we will use this contrast visualization for the treatment plan only. So now a lot of papers have been published and most of the data shows that from 3, 9, 16, 17, now most of the data shows that if we are planning with the help of CT scan and if we are planning with the help of the PET CT scan, in most of the cases there is either increase in the gross tumor volume or there is a decrease in the gross tumor volume. So it always changes your treatment planning. So PET CT always change your treatment planning. If you are planning your radiation therapy with the help of the PET CT, definitely you will get a lot of benefit over CT images. And one more thing that if we are planning with the help of the PET CT is the whole body image. So many times, around 20% times, you are getting the metastatic areas, like if you are getting for the lung region, and you will get the metastasis in the bone, solid limits or something. So it also helps in that way. Now, like in the customized esophagus, we are usually planning with the help of the CT, and also we will go with the endoscopy. But if the region is large and the entire lumen is occupied, and we cannot negotiate our scope through the lumen, so in that case you cannot find out, and you cannot actually find out the distal end of the disease. So PET CT will always help you to find out the exact distal end and to find out at which particular level the disease is being going to be end. So and also one more condition. If the disease is submucosal and it is small disease, so we cannot pick it with the help of the CT scan, and also we cannot pick it with the help of the endoscopy. So in that scenario also, PET CT is very helpful for the treatment planning. One more example I will show you from the customer lung. In the customer lung, as you can see in this image, this is very difficult to shoot a flying bird. But if the body is staying at single position, then you can shoot it easily. So lung is the flying bird in our body. So we can easily delineate the volume of the lung region, lung planning. Like if the region is around the bronchus and there is anti-necrosis of that particular segment of that particular lobe. So CT will not be much helpful. If you can see this image, there is a region around hyla and it leads to the collapse of entire upper lobe. So in the CT image, it is very difficult to delineate the exact tumor volume. But if we will see the PET CT image, in PET CT image we can see this is the tumor and this is the affected area, this is the inflammatory area. So if you will plan on the basis of the CT scan, definitely you will take more area. And if you will take more area, then the dose will be delivered not the precise dose will be delivered. And you will deliver the dose to the normal cells also, which will definitely create a side effect. Also, in the stage 3 cancer patients, if the contralateral node is there, it is 1 centimeter, 2 centimeter. So CT will not tell you the exact condition of the lymph node, that it is metastatic or it is non-metastatic. But if you will go with the PET CT, and if significant uptake is on that area, on the opposite side, then definitely you will say that this lesion, lung lesions also, lung cancer also, And in almost every stage, you can see that GDP change to 30-60% and nodal status change up to 51% if you will plan with the help of the PET CT in place of the CT scan. Similarly, in the customer service, if the para-aortic lymph node are present and CT scan definitely will give you a picture of the loco-regional disease. MRI will also give you the picture of the loco-regional disease. But if the lymph nodes are present in the para-aortic, in infra-renal position, then you have to decide, and especially if the lymph node is less than 1 centimeter, then you have to decide the planning that you are going for the curative intent or you are going for the palliative intent. In that scenario also, if you will get a good information about the status of that lymph node, because multiple times if the lymph node are sub-centimeter size, so it will be very difficult to target those lymph nodes with the FNC. So with the help of PET CT, if the uptake is there, definitely you will be more strong, your mind will be more positive that this is a metastatic lymph node and we should plan for the palliative chemotherapy. We should not go for the definitive radiotherapy. So it is very helpful that this data of coverage, and you can see that MRI sensitivity of the MRI for the nodal disease was 30%, but for the PET CT it was 58.6%. And this is very high for both the modalities, and accuracy was more with the help of PET CT. Now we will come for the carcinoma breast. In the early stage 1 and stage 2 disease, usually people say that we are not recommending this PET CT for the early stage disease. But how it will help you in the reduction of if there is a lymph node in the intermedullary region, and it is a small lymph node around 4 mm, 5 mm, and now you are in the dilemma that it is metastatic or it is not metastatic, and you have to plan your radiotherapy planning accordingly. So if it is metastatic, then you have to cover now we are doing the hypoxia imaging, we are doing the neoangiogenesis imaging. So if we will go for the hypoxia imaging and neoangiogenesis imaging, how it will help you? Like in this case, this is the first line is the F18 FDG PET CT, and it shows that the entire tumor is grossly hypermetabolic, and you will plan for the entire tumor similar dose. But when we will go with the copper 6480 SL imaging, this is the hypoxia imaging modality. You can easily see that the more hypoxia was on the periphery. So what you will do now, initially you were planning to go for the similar dose to this entire region, but now you will deliver more dose in the periphery and less dose in the center. So it will definitely give you the good outcome. So this phenomenon is called the dose painting. So what dose painting we will do? We will deliver more dose to those areas which are hypoxic, which are more neoangiogenesis, and which are more hypermetabolic. So you can modify your dose delivery in the uniformly homogeneous and uptake was homogeneous. Later on, when you are doing the PET CT after 3 to 5 fractions, you can see that now there is no homogeneity now. Now the environment has changed, and you can also change your treatment plan accordingly. The area which are more hypermetabolic, the area which are more hypoxic, the area which are more neoangiogenetic, so you can deliver your dose more on those areas. So this is called the adaptive radiotherapy, and this will definitely give you the better outcome for the treatment of your patient. So now the conclusion, PET CT is helpful in each and every step of your treatment planning, on your staging also. If you are doing the staging with the help of the PET CT, definitely you will see there 10 to 20% patients which were initially for the definitive radiotherapy or chemotherapy or treatment, they converted into the palliative conditions, and now that there is no need for the definitive treatment. So you will save the money and the side effects, and also in the planning you will get more accurate gross tumor volume, so you will easily find out, you can easily plan that how much dose you have to deliver for the patients. So this is a joint work of radiation oncologist, nuclear medicine physician, radiation technologist, and nuclear medicine technologist, and other part of the system. So thank you so much. This is a very small talk for the planning. Is there any question, please? Thank you, sir.
Local request again. So for these cases, these hypoxia and converted research studies are can be used or not? My question. There are two questions. Please answer.
Treatment of the head and cancers. This is one question. And what is the difference for the PET CT and MRI? PET MRI. So basically PET MRI is a very good modality, and similarly as for the MRI. If you are using PET MRI for the prostate lesions, you are using the PET MRI for the brain lesions, but it is not much helpful for the head and neck and other part of the areas. Like you have to code it like this, that this is the PET CT, this is the PET MRI. So where you are using the CT for the planning, there you should use the PET CT, and where you are using the MRI for the planning, at that place you have to use the PET MRI. Now second thing is this, that PET MRI is not very common. It is available only in 1 or 2 centers in India. So that's why it is not very useful right now for the remote areas. And your second question is hypoxia imaging. So definitely there are a lot of agents for the hypoxia imaging, and it will help you for the primary tumor treatment or a bulky lymph node disease. If you go with the hypoxia imaging, you will find out a lot of areas which are very much hypoxic, and you have to deliver more dose in those areas which are hypoxic, and you have to deliver less dose in those areas which are not hypoxic. So definitely it will help you in every part of the body. If we are going to image with the hypoxic imaging agent, we will get good results.
The role of SUV value in adaptive radiotherapy.
Definitely there are 2 or 3 methods, and second one is the target to background method. So in many areas, when we are going to plan, we have to give a cutoff value. Like if we are going to plan for the lung cancer lymph nodes, if the SU value is more than 2.5 or less than 2.5, this is a simple system. You will feed your 2.5 value in your system, and you will get those areas which are more than 2.5, and you can plan them accordingly. So SUV definitely have a very good role, but in many areas where SUV is not helpful, like serious tumors and many low metabolically active tumors, in those areas we have to find out the background, like normal uptake in the background, like in the liver lesion, normal uptake in the normal liver, and then you will calculate the target tumor area, SUV, and we will compare both. If it is doubling, like in the background it is 1 and in the lesion it is 2, then we will target that area of the 2. So definitely SUV has a significant role in the treatment planning.
You also palpation. For head cancer, sometimes you see you do many FNACs, biopsies, and still that tumor is not, you are not getting tumor positive, and instead you just repeat biopsies. So, and you don't know what to do. In prostate you do MRS, in head neck you can't do MRS. So MRS is not been proven. So in that scenario, when you are getting multiple biopsy negative, and there is, you see the huge tumor, there is a unedited proliferative hyperplasia. So I was asking about that thing. That is, you are having a advanced marginal negative. So what is that scenario? Another scenario is you are getting the lymph node negative, but that lymph node, if you again do RT-PCR,
I would like to request the question to be short and precise.
Is a deadly cancer, so you should give more time. But you have yourself told that there are no cases which are you can do for getting the pollution for the pollution thing. That is, you can tell even if biopsy is negative, it is cancer. So I wanted that to ask.
Definitely histopathology and analysis are gold standard for any treatment planning. If you are going to the PET CT and you are getting a positive lymph node, and if it is negative on the FNAC, and if it is negative on the biopsy, definitely if it is negative on the biopsy, you should not plan you should not take it in your planning. But if it is the FNAC negative, and clinically you are seeing that this is the local regional draining area for that particular tumor, and FDG uptake is significant in that lymph node, then definitely you should take it in your planning, nodal planning.
What is the standard SU activity to say it is significant? Does it vary the primary with the lymph node, and third is the metastatic, number 1. But you said about as per the uptake of the liver, but I have seen patients who has got a background liver uptake of more than 3. Does the background uptake vary with the cirrhosis, etc.?
Voice is not very clear at this point. I am not getting the question.
The primary lymph node status or the metastatic side, number 1. You said clearly that according to the background your activity is in a system. I have seen a patient who has background activity. And certainly I'm sure that it's not correct. I mean, whether this background liver activity will vary in the cirrhosis, etc. conditions. Number two, and how it is answered. Like hypoxic mode, is it we need to order separately or you do it as a part of your pregnancy?
No,
That is the second thing. Third thing, during the interim, whether to take the primary as a correct assessment of reduction of the thing or the lymph node or both, and you said it's a hypoxic mode in combination with MDC. Something you said. Make it clear for that.
So basically, staging. So we should not go more than 2 times imaging. PET-CT should be done on the flat couch as we are doing for the CT, and it should be the planning PET-CT in cases of planning CT. Number 1. Number 2, SUV. There is no definitive cutoff value for the SUV. Like some people are asking every day to me, what is the cutoff of the SUV value? That this is a metastatic, this is a malignant, and this is not metastatic and not malignant. So there is no definitive cutoff value, but usually we can say that 2.5 to 3, which we have seen in our practice, it is significant value. If the value is more than this, then we consider it as a significant, which is probability is very high. And always we use that if the SU value is less than 2.5, then we should go with the target to background ratio. If the target to background ratio is double, like the lesion is in the liver and the SU value is 2 and the background value is 1, then this should be considered as significant and we should consider it in the planning. Third thing is, you just do orthogonal lymph model. We should consider both the sides, the lymph sides as well as the planning side during the planning with the help of the PET-CT. And hypoxia imaging is always helpful, but it is not very common because the agent are quite costly right now, and most of the centers are not doing it. This is available in the only some APEX centers like AIMS and few private centers. So this is not very common, but this is definitely helpful if you will deliver more area in the hypoxic areas, more in the hypoxic area, you will get better results.
Now we would like, and dear friends, today it's a privilege for me to present over here. And first of all, I would like to thank for methods of imaging the tumor hypoxia and what is the applications of tumor hypoxia imaging in cancer management. And I will show some of our published work in scientific article in the journal. Now, tumor hypoxia, this is the distribution of oxygen partial pressure in tumor tissues in the particular interest of radiation oncologist, particular you can say oncologist, because the therapeutic resistance of the tumor tissues that depends on the partial pressure of oxygens in the tumor cells. So tumor cells living under adequate hypoxic or hypoxic conditions are relatively resistant to the any kind of therapies like chemotherapy and radiation therapy. Now, in history, tumor hypoxia, in 1953, Cray first described that the oil oxygenated tumor cells are responded twice as well as radiotherapy than the hypoxic cells. And first, the Robinson et al. Proposed that tumor hypoxia in human lung tumors, and in 1992, first Sevenja described the HIF factor, that is hypoxia-induced factor in the tumors, and he got, and there are so many developments are there, and in 2019, the William Kelmy and Peter Radcliffe and Greg Sevenger won the Nobel Prize in the medicine because of this, because their work in the tumor hypoxia. Now, tumor hypoxia, it's the main features of the solid tumors, one of the main features of solid tumors, and it develops because of uncontrollable cell proliferation, altered metabolism, abnormal tumor blood vessels functions, convolutions, and it's related with the aggressive tumor phenotype, chemo and radiotherapy resistance, and poor clinical outcome. Now, tumor hypoxia-induced factor (HIF). This is a complex. This is a protein that is complex type of protein which plays a vital role in when the cells are under very low oxygen conditions, and it actually activates the genes to reacts the body cells towards the low oxygen, their survival, their growth and their repair. And oxygen enhancement ratio. This is the ratio of radiation doses during lack of oxygen with the yoxic condition versus the oxic condition. And OAR depends on the aridity. And this is the very common graph which we have learned during our study time. That is OARs. This is first one is the aerated condition, and this is the hypoxic condition which requires higher dose. So there is ratio of dm divided by dA. This is the OER. And these are some potential factors for tumor hypoxia. You can see that there are some carcinogenic factors which impair the endothelial cell shape and functions in the vascular system. Also, the tumor microenvironment is remodeled, and tumor cells, stromal cells and stromal components resulting in the vascular deformations due to the pressures, which also causes the tumor hypoxia. High metabolism in cancer cells such as increased nucleic acid synthesis which leads to the related hypoxia. The dysregulated proliferation and alignment of endothelial cells results in the formations of non-functional blood vessels. This is also can cause the hypoxia. With increased distance between tumor cells and blood vessels, the O2 diffusion decreases and may cause the tumor hypoxia. Now, tumor hypoxia, there are many types. First of all is transient hypoxic cell, chronic hypoxic cell, and some tumors may have both type of components. So, tumor may include 3 different types of cell populations. First type is chronically hypoxic cells. If they left in situ, the cell die and it does not affect the response of the therapies. And the second type of chronically hypoxic cells that are very virally left in situ, if it's left in situ, then these cancer cells stimulated by hypoxia to promote proliferation, which alter the gene expression, and it can enhance the cellular drug resistance and radiation resistance. Now, third type, there is a transient hypoxia, and which we are exploited during our fractionation scheme. Now, this is the hypoxia and carcinogenesis, where the hypoxia can promote the carcinogenesis by the inducing these HR and reducing this MMR repair process by this double standard break and single standard break, and the H1 alpha is upregulated by all these pathways, and sometimes there are deletion of P53 genes because of this tumor hypoxia, and H1 alpha derives to HIF1 beta that enters the nucleus to bind the HRE, and it promotes the cell proliferation, the migration, the invasion, the EMT, and the angiogenesis. The hypoxia and cancer cell behaviors, it's well known that patients who has primary cancer are hypoxic, obstructive pulmonary disease tend to have poor prognostic outcome. Now, there are various methods of hypoxia mapping, that is oxygen electrodes, magnetic resonance MRI, and nuclear imaging studies. This is already described by my earlier speaker, Dr. Narvesh, and optical imaging. And I will show you one new imaging that is known as photoacoustic imaging methods, where by which you can very well image the hypoxic body. So these are the MRI techniques. The clinician may describe this very well. That is, there are 4 types of cancer tumor hypoxia imaging by MRI. First is oxygen enhanced MRI. That is, these methods, the MRI scan with oxygen and without pure 100% oxygen. These two oxygen conditions, the MRI signal changes, and where we can map the hypoxic area. And gold MRI, that is blood oxygen level dependent hypoxic mapping, where the blood oxygens, there are two types of, one is oxygenated, that is dimagnetic, and another is deoxygenated, that is paramagnetic, and which creates differences in the images, by which we can map the hypoxia. And another is diffusion MRI and DCE MRI. I know there are some institutes which can incorporate these imaging during their planning methods. And these are some imaging of hypoxia mapping by MRI. This is gold MRI. Now, already my previous speaker, Dr. Narvesh, expressed that there is a very urgent need to see the hypoxic volume during planning. So he mentioned in detail and discussed about the various tracers are available. These radioactive tracers that is activated in low oxygen environment, that they are injected. The most common tracer is 18F-MISO and FAZA. These radio tracers, which are reduced by our enzymes in hypoxic cells, and they are become trapped in the hypoxic volume, and they can be imaged. So these are some tracers which are used in various malignancies. This is a FDG versus hypoxia tracer images. So these are some merits and demerits of plate imaging. We have limited resolutions, we have quantification variabilities, we have tracer specificity because here ionizing radiation is involved, and already mentioned that there is a cost effectiveness is the cost is high, of this very high for this tracer. Now I am going to present this photoacoustic imaging. This is a different kind of a new kind of imaging modality by which where we can listen the light, and this is a generation of sound by absorption of light, where a nanosecond pulse laser light emitted causing a illumination to the tissue, and which absorb the chromophores lights thermoelastic pollutions, and because of this expansion or vibration, there is a generation of very low signal ultrasound. These signals can be captured and can be processed by our software processing software. Now these are some benefits of photoacoustic imaging, where we have combined the optical resolution with the acoustic path depth penetration. Photoacoustic imaging offers the structural, functional and molecular and kinetic information of the cells, and it's a very promising potential for preclinical and clinical. And in 2022 we have procured the photoacoustic imaging for preclinical imaging purpose. This is the high frequency versus clinical ultrasounds, where we can image a human. This is a low frequency, and this is a very high frequency, where we can image a mice of 30 grams. So these are the advantages. This is a high throughput longitudinal study is possible, and this is non-invasive. So this is our system, and these are accessories of our system, and these are some specification, ultrasound specification. This is approximately 70 megahertz with resolution of 30 micrometer. These are lasers are used in this imaging system, and we use rats or mice. They are commonly 30 gram to 300 gram body weight. We can image, and we use these kinds of tumor models, that is syngenic models, the carcinogenic, genetically engineered model, and carcinogenic induced model, and patient-derived xenograft model. So we normally use this one, where we induced this DMBA, dissolved in 0.5 ml of vehicle sunflowers, and they are injected, and after some time they develop the tumors. These are the image acquisitions. This is the probe of ultrasound. So you can see this is actually the hypoxic area which is black, and the red one is oxic area. This is the tumor. And these are other methods by oxygen electrodes, and ISC methods are also available for imaging the mapping of hypoxic volume. Now these are the applications of mapping of tumor hypoxia. First, we can predict the tumor treatment response, and we can personalize the treatment. So we can stratify the patients for different treatments, and patients with hypoxia tumor may benefit. They can be designed with the different kind of therapies, and specifically to overcome the hypoxia. And we also develop new therapies. We can optimize, as a radiation oncologist or radiotherapy professionals, we can optimize the radiotherapy treatments, and we can decide the best plan or different plan for to overcome this hypoxia. We have various means that I will discuss. These are the mapping by which we can design our individualized patient plan. Now we know that there are 5 highs to overcome the radiotherapy, and that is first is hyperfractionation, and second is high dose or additional dose for the hypoxic volume. If we can map these hypoxia sensitizers to overcome the hypoxia, we can use the hyperbaric oxygens or carbogen addition with the radiation therapy, so that patient can be benefited. So these are our some published papers in scientific articles. Thank you. That is the cellular molecular information of the cell that can be received by the cell.
Why are you using on mouse only? Why are you not using on patients?
No, this is
Patient with tumors, renal tumors, breast tumors.
no, the others are high frequency. This is actually preclinical machine. We have installed. This is a preclinical machine for preclinical research, not for patient. And it can there are sufficient precautions or protections is covered for the patient safety.
Tumor is producing biophotons, that coherent photons, and the range of data range of beta range, and the normal tissue producing in the range of infrared. So are they can be used biophotons?
Yes, sir. We are using lasers, high energy lasers, to illuminate the tissues.
Thank you again.
Present the memento of appreciation to our esteemed speaker, Dr. Diksha Chaturvedi, as a token of gratitude from the organizing committee.
सर look here, sir.
Thank you, sir. With due respect, invite our honorable chairperson, Dr. Vikram Agarwal, sir, to present the memento of appreciation to our esteemed speakers, Dr. Navesh Kumar, sir, and Dr. Abhijit Bandhu.
Look here, sir, camera. Thank you, sir. Look here. Thank you, sir. Thank you.
you, sir.
I would like to call upon our next chairperson for this session.
Optimal treatment for advanced laryngeal cancer, especially for organ preservation. Dr. Gupta.
Good morning, everyone. Thank you, Chairperson. And at the outset, I would like to thank the organizing committee for inviting me, especially Dr. Chaturvedi, Dr. Diksha, and Dr. Mamun Khan for their very hard work. Thank you very much. And the task given to me is to present the optimal treatment for advanced laryngeal cancer, especially T4, in the context of organ preservation. So I have no conflict of interest, and these are my outlines for the presentation. So we know according to AGCC, the TNM staging, T4 tumors of larynx has been divided into T4A and T4B. What is T4A? When the tumor invades outer cortex of the thyroid cartilage, trachea, soft tissue, strap muscles, and esophagus. And T4B is when it involves the prevertebral space, mediastinal structure, or in cases carotid artery. So, till 1990, the treatment of choice for locally advanced laryngeal cancer was only surgery, total laryngectomy. However, we know it's a morbid procedure. Patient loses their natural voice, difficulty in swallowing, and with the permanent tracheostomy comes the emotional and cosmetic impacts. So there was a need for improvement in these parameters. So what are the approach? That is organ preservation. How can we do this? With chemoradiation. So why we need it? Every one of us would like to have his or her natural voice or speech and to have normal swallowing function. No one likes permanent tracheostomy, it has its own side effects, and everyone wants better quality of life. So this was the rationale for starting organ preservation in laryngeal tumors. So several pilot studies were done where before surgery induction chemotherapy or some chemotherapy was given, which has shown high rates of complete regression, prolonged survival. So with this in mind, Veteran Affairs study was started. I am talking about early 90s. In this study, randomized trial, more than 320 patients were randomized into upfront surgery followed by radiotherapy, and in second arm it was induction chemotherapy followed by definitive chemoradiotherapy. And those patients who received induction chemotherapy, if they developed complete response or partial response, they were given definitive radiotherapy. And if there was no response, they underwent surgery followed by radiotherapy. So, at 2 years, 2/3 of the patients were having their larynx, means larynx was spared. There was no surgery required, and 2/3 were free from the disease. So, it was a very encouraging result. So, this was the Veteran Affairs Laryngeal Cancer Study Group was the first study, randomized trial, which showed the induction chemotherapy helps in organ preservation. Another trial was started, EORTC trial 24954. Where induction chemotherapy cisplatin 5-2 to 4 cycles, and patient was randomized into those patients who received who had complete response or partial response, they underwent definitive chemoradiotherapy. And the 3-year survival was 57% with chemotherapy, 43% with surgery arm. And the estimated organ preservation rate was 42%, which was quite good. So we have the long-term update also, with median follow-up 10 years. The functional larynx preservation rate was around 20%. 1/5 of the patients at 10 years were able to spare their larynx. Then there were GORTEC trials, 3-4 trials, GORTEC 8901, GORTEC 9401, and GORTEC 2001 trial. And what they have shown that concurrent chemoradiotherapy is superior to RT alone, and induction with TPF chemotherapy improves both local control and organ preservation. So we all are aware about McKenzie meta-analysis, which was published in 2000, which has shown that concomitant chemoradiation there is 8% survival advantage, and overall, if we combine adjuvant, neoadjuvant, and concomitant, 4% survival advantage. So this important landmark trial, Interglobe RTOG 9111, is compared more than 500 patients of stage 3 and 4, glottic and supraglottic, 2/3 of patients who are having supraglottic disease, they were divided into 3 arms: induction chemotherapy followed by RT versus concomitant chemoradiation and RT alone. And at 2 years, the survival was 68%. It was no difference between chemoradiation versus surgery. And at 5 years also it was same, 45 versus 42%. And the laryngeal preservation rate at 5 years with concomitant chemoradiation, it was as high as around 84%, and with induction 72%. So the conclusion of this intergroup 9111 trial is that patient with laryngeal cancer, locally advanced, CT-RT superior to induction chemotherapy followed by radiotherapy or radiotherapy alone. So this RTOG 9111 established a new standard for laryngeal preservation by demonstrating the superiority of concurrent chemoradiation for achieving local control and laryngeal preservation. So this is the summary table for laryngeal preservation landmark trials, veteran affairs. We have seen 2/3 of the patients in organ preservation with Gorakhpur trial with induction TPF around 70%, and RTOG intergroup 9111 around more than 80% of patients were having laryngeal preservation. And now we have the long-term results of this RTOG 9111, and at 10 years also 82% patients were having laryngeal had their larynx preserved. And we can see in the Kaplan-Meier CT-RT performing better. So coming to another issue, what about quality of life after laryngeal preservation? So we know about the survival rate is around 60%, so 40% of the patients with locally advanced laryngeal cancer are dead by 5 years. So this diminishes the number of patients available for long-term quality of life study. And this quality of life study was not done in Gorakhpur and EORTC trials. In the intergroup RTOG 9111 study, formal long-term quality of life and functional measure assessment was done using validated questionnaire. So what was the result? It showed no differences in solid dysfunction or diet alterations could be detected among patients in the 3 treatment group, both in induction or concomitant RT alone. And 1/4 of the patients reported diet alterations, but less than 4% were limited to liquids or could not swallow. And inability to swallow was reported in less than 3% of patients in all treatment groups. And there were no differences in speech or voice quality. It's a very good encouraging result. But after that, there is no randomized or prospective trials. We have review of literature or meta-analysis. So we'll see further. So this study was published by Narayana et al. In 2018 for organ preservation protocols in T4 laryngeal cancer. And they have said that all patients of T4 laryngeal and hypopharyngeal cancer are not a suitable candidates for organ preservation. And this modality should be offered only to selected patients with good performance status. We have data from Nancy from Memorial Sloan Kettering, New York, USA, and they have published their outcomes for organ preservation and chemoradiation in T4 larynx and hypopharyngeal cancer. They have said that they have reported better than previously noted outcomes among T4 larynx and hypopharynx patients who have unresectable disease or refused surgery. We have another study recently published in 2024. Outcomes of organ preservation versus surgery was compared, and they have suggested that the definitive radiotherapy in laryngeal cancer does not lead to a poor outcome than total laryngectomy. And in T4 patient, our findings should reassure clinician or patient about the viability of definitive radiotherapy as a treatment option. So we have 2 meta-analyses also published, one by Tang et al. And what they have concluded that they support or meta-analysis shows total laryngectomy for patients with T4 laryngeal cancer, they are doing better. This is the forest plot. We can see the surgical arm, especially in T4, they are performing better. Another meta-analysis published from Brazil, again they have shown better outcomes with surgery. However, this is the result. The surgical treatment was associated with better survival outcomes. MN is defined by T stage. While patients with T4 stage have less risk of mortality with total laryngectomy, and there is no difference between the different treatments for patients with T3 tumors. And surgery is related to a lower chance of recurrence, legislation, feeding tube dependence. This is meta-analysis result. However, there are several drawbacks. there is potential interaction and crossover between several evaluated factors which could not be controlled in this meta-analysis. In addition, when they have done subgroup analysis, their number of patients is very small, and this has a potential impact on the results. There are issues. We have seen all the latest meta-analysis or trials are based on retrospective data. Where in the 90s we have landmark trials, veteran affairs and intergroup 9111. So, and they have shown contrasting results. One of the reasons is inclusion of advanced stage disease. In organ preservation, more advanced like T4B patients were also included, where in surgery they were more lesser bulk of disease, smaller T4A disease. And there is no level 1 evidence supporting a non-operative organ preservation study for these patients. And another is like with definition of laryngeal preservation. So when you're doing meta-analysis, different studies have done different inclusion criteria. And the underrepresentation of T4 laryngeal cancer in the prospective and the observational studies is the reason for superiority of surgical management. So as of now, according to NCCN, for T4A tumors, they recommend surgery followed by radiotherapy, and they are recommending conservative organ preservation only in patients who refuse surgery in T4A disease with induction chemotherapy followed by concomitant chemoradiotherapy. So, according to American Society of Clinical Oncology Clinical Practice Guideline, they published 2018, they say for patients with locally advanced T3 or T4 disease, organ preservation surgery combined with chemotherapy and radiation or radiation alone offer the potential for larynx preservation without compromising overall survival. And for selected patients with extensive T4 or large T4 lesions and or poor treatment laryngeal function, better survival rate and quality of life may be achieved with surgery. And the bottom line is, according to ESCO guidelines, all patients should have multidisciplinary evaluation regarding their suitability for a laryngeal preservation approach, and there should be a price of these treatment options. So, better selection of patient for organ preservation is the key. We can take T2, T3 or small T4A tumors for organ preservation, having without massive cartilage invasion or extension into the soft tissue space, and without laryngeal dysfunction like tracheostomy or nasogastric tube dependence or pneumonia, with age less than 70 years, a fitter patient who can tolerate chemotherapy and good performance status. So in conclusion, based on our decision for organ preservation or surgery should be based on post-chemoradiotherapy, laryngeal functions in terms of aspiration, dysphagia, stridor, voice quality, rather than just looking for T stage. Currently, there is lack of recent randomized data about oncological and functional outcomes in T4A laryngeal tumors, and prospective trials are needed. With current day scenario where we have IMRT, IGRT, MR line and proton therapy. Organ preservation is certainly a treatment option for advanced laryngeal cancer, including all small T4A disease, especially when patients refuse surgery or are not a surgical candidate because of other comorbid reasons. And the treatment option, laryngeal preservation is definitely a treatment option for patients in developing countries with limited voice rehabilitation facilities and poor socioeconomic conditions in carefully selected group of patients. So I thank you all for your kind listening, and I take this opportunity to invite you all for the next UPAROI conference, which will be held in our institute. So I welcome you all for the next conference. Thank you very much. Sir, can you tell your experience?
So it is a gray area, I would say, and the criteria for selection have to be really strict. That now we have MRI, which can tell us early cartilage invasion. Sometimes we see in CT scan it is mentioned it is a low cartilage invasion, and it is T3 tumor. We take up for chemoradiation, and ultimately we find that the salvage or the voice quality and swallowing was not as good. But MRI can really pick up early cartilage invasion. So T4A early cartilage invasion, we can do chemoradiation, but a significant cartilage erosion with even if they get local control, they have frequent episodes of escalation pneumonia. They keep coming to you with pneumonia and we say it is community acquired pneumonia. No, it is silent escalation which increases after chemoradiation. So up to T3, chemoradiation, very good, organ preservation is one of the highest. But when there is a significant cartilage invasion, then we should think about surgery.
And there is the mass, there is a disease, and there is lymph node. Within level 2 to 4. How will you manage that?
It is like how simple methods can, delay or postpone or even hamper the quality, not hamper the quality of life of the radiotherapy. So I'll be talking about thyroid, because thyroid is an organ which usually I don't know, most of us don't take care of that too much. So most of the heart head and neck cancer, they do receive chemoradiation or radiation post-operatively, especially stage 3 and stage 4. Frequently, thyroid is frequently exposed to collateral radiation, and radiation-induced hypothyroidism, that is what I'm going to talk about, is a well-recognized late toxicity, and there is data that this is the most common late toxicity of head and neck cancer radiotherapy. So what is the rationale of thyroid sparing is that suppose you have treated a T3 and 0 cancer patient of buccal mucosa treated with surgery and radiotherapy, and that patient develops hypothyroidism. Now it creates a logistic and financial burden on that patient, especially the patient from remote area. Impact long-term quality of life and survivorship. And this is this meta-analysis. It is not actually done on cancer patient, but it is done on hypothyroidism, and it has shown that subclinical hypothyroidism has an increased chance of heart diseases and mortality. So we have treated with cancer, but then we have just because we were not so careful about the thyroid, we have put that patient into a long-term risk. So what is the impact? It can be classical hypothyroidism, where the patient comes with proper symptoms like cold intolerance, fatigue, cognitive impairment, and menstrual irregularities. And then there is subclinical hypothyroidism, which is even more dangerous because we don't take care of it, and it is often misdiagnosed or undiagnosed. It can cause dyslipidemia, increased cardiovascular risk factors, detrimental effect on fetal brain development during pregnancy. That is also an important factor. Now, if you go about the incidence, so it can start anywhere from 4 weeks up to 20 years after clinical radiation. There is evidence that up to 20 years after clinical radiation, and with peak incidence of around 1 to 2 years. The most commonly, these are the lines from different review articles. The most commonly occurring radiation-induced hypothyroid dysfunction is primary hypothyroidism, either subclinical or overt hypothyroidism. Approximately in the range of 20 to 40%. So it is a large number of patients that receive after receiving radiotherapy develop hypothyroidism. And RT-related hypothyroidism has increased over time, obviously, because we are picking up cancers early, we are treating with surgery, radiotherapy, chemotherapy, and longer follow-ups also. Now, there is this review article which has shown that incidence of around 11 to 50% across historical series. 50% of the patient, you just imagine 50% of the patient after radiation, and most of the patients who get cured, after 2 years, they don't even come for follow-up. And among those who are diagnosed, approximately 30 to 50% of the patients do not get optimal thyroid replacement therapy. They are either over replaced or under replaced. And hypothyroidism, it is again a review article which also showing that many of the review articles, they also show that the incidence of hypothyroidism is actually around the range of 50%, which is quite high. Now, type of hypothyroidism, there can be a clinical definition where I told the patient will come with proper symptoms like weight gain, cold intolerance, and fatigue. And then there is biochemical definition based upon the level of T3, T4, and TSH. It can be classical hypothyroidism, like in which decreased T3, T4, and increased TSH. It is easy to diagnose because most of these patients, if they are not replaced, they will have symptoms in sooner or later in 2, 3, 4 months. But then there is subclinical hypothyroidism, which is in which the T3, T4 levels are normal, but TSH is increasing gradually and may cause symptoms later on. Now, what is the mechanism of radiation-induced hypothyroidism? It is not completely known in different series and in different articles. If you search about, most of them are saying it is autoimmune. in which autoantibodies are produced against cellular component of thyrocytes. Again, there is not fully clarified, however, it is related to thyroid cell fibrosis, the vascular proliferation, and the immune response. So these are the factors that can contribute to radiation-induced hypothyroidism. Now, what are the factors impacting radiation-induced hypothyroidism? This is also a very important factor. It can be patient-related and it can be treatment-related. Patient-related can be age, gender, and then there are pre-existing conditions. So, why age? Why there is a question mark on age? Because there are many controversies regarding age. Some articles shows that early age and some articles shows that late age more prone for hypothyroidism, radiation-induced. It is not clarified because there is not too much paper, not too much article on this, so it becomes sometimes difficult to actually predict whether early or late age is more responsible. Gender, females, thyroid problem always be more in females. Now there are two more factors that we will see later on. If females have more prone to radiation-induced hypothyroidism because of the different reasons. And then there can be any thyroid pre-existing disease which can even prone the patient to more chances of radiation-induced hypothyroidism. Now these are the factors that you can't do anything because these are patient-related factors and they are not modifiable. But then there is treatment-related factor. What are they? Yeah, like combined modality of treatment, techniques. It is whether you are treating unilateral, bilateral, nodal burden, subsite, chemotherapy, immunotherapy, and then this common drugs. Now, if we try to just break down the common drugs, what are the common drugs that can cause hypothyroidism? Now, suppose you are a patient who is not taking this kind of medication, he might tolerate a higher dose of radiotherapy, but when patient is taking these drugs, he might not tolerate the same level of dose. So you can't just say हमारा ये radiation का dose है and that you will follow this only protocol. You have to individualize each patient. So these are corticosteroids, amiodarone, lithium, metformin, rifampicin, carbamazepine, quinine, and furosemide. These are the common drugs that can cause hypothyroidism and that can put patient at risk. So now we'll talk about what are the factors that are predictive. So this is again a review article which shows that the mean pre-thyroid treatment thyroid volume of approximately 18 cc in this particular study, the thyroid volume was about 20, 30 and 40% at 6 to 30 weeks. The more you follow the patient, the more is the volume loss of the thyroid gland, and that is why females are more prone because in the average thyroid volume in female is less, approximately 20% as compared to men. Now, if you see this, these are the studies that have shown. If you just try to focus, that apart from the doses that are given to thyroid, if you see in many of the studies, they will see the significant predicting factors like the thyroid volume, gender, age, thyroid volume, again female thyroid volume. So you see, many of the cases, thyroid volume is a very important factor. So when you are doing the treatment planning, when you are controlling, you need to see the thyroid volume. If you are able to, see thyroid volume, and then you can give your consent according to that volume. One of the interventions preventing radiation-induced hypothyroidism. So there is a field we are giving radiotherapy. Either you can move the thyroid from that field, or you can reduce the field size. There are two options you can do. So people have done thyroid transfer also. This is the article in which the patient was during surgery. The patient thyroid was shifted from the neck to the upper limb, and then there is other in which the thyroid transfer was done to the anterolateral aspect of the thigh. Although these studies contain only 6-10 patients, you cannot draw a conclusion from this, but these approaches have been tried, and the mean additional time for procedure was 51 minutes. Giving 1 hour extra during surgery, it becomes sometimes difficult for the surgeon, especially in the high volume centers. And in this particular study, 6 patients were there. Out of after 8 months of follow-up, out of 6, 5 patients were thyroid. Now we will come to our job. What we can do is that we can do either thyroid sparing or thyroid optimization. What is the difference? Thyroid sparing is a physician job where you do the modification in the controlling, and then you give your physicists to do the proper planning with a proper discussion, and then there is optimization. You don't change the contouring too much, but you tell your physicists that we want this particular dose constraints. So there was this paper, this thyroid optimization and thyroid sparing radiotherapy in oral cavity and oropharyngeal cancer. In this, what they did, they took 10 patients. They were initially, it is a retrospective study and only dosimetric study. They did a thyroid non-optimized plan, and after some time they do again 2 more plans for each patient, like thyroid optimization and thyroid sparing techniques. And what they found is that, so this is the thyroid non-optimized plan in which the chronological contouring is done, no constant to the thyroid was given and the planning was done. So next, this is thyroid optimized, no change in contouring, just you give constant to the thyroid gland. And then the next, this is in which you have just cropped the PTV from the thyroid gland. So obviously, if we talk think logically, it will definitely have a less dose as compared to thyroid optimized. So thyroid sparing is definitely a good option for preserving thyroid, getting higher dose. But is it really feasible to do in each every case? It is not like that. So in thyroid non-optimized, in that particular trial, what they found is that the mean dose to thyroid was 55 gray. When they did the thyroid optimization, what they found is that the mean dose was 43 gray. And when the thyroid sparing was done, that is the contour was cropped from the thyroid gland, they found that the mean dose was around 30 gray. Again, there is this article from Ambient retrospective analysis, 10 patients, I'm article in 2023, treatment plan were compared for each patient. Her patient with thyroid non-optimized, optimized and sparing compared, and dosimetric parameters mean thyroid dose and dose coverage. Obviously, it is no clinical rocket science that in these kind of plants, if you will see all the plants, you will definitely know how this thyroid sparing plant will have a lesser dose to the thyroid gland. But should we do it or not? I don't know. So what am I doing at Medanta? There was a confusion, like why did this all started with thyroid, but there was a patient we treated with NSCT, then we reported, we came with a large neck node, we did CTRT. At that time I was not taking too much care of thyroid. Later on that patient developed recurrence because of other things, and during this palliative chemotherapy phase he came to me कि सर इनका thyroid नंबर आ रहा है, अगर कीमो ही करानी थी तो इससे अच्छा होता कि हम रेडिएशन कराते ही नहीं. So then it came कि नहीं, we should think of thyroid also. So then it all started, and so I am being selected depending upon the site, the nodal burden, the level of nodal involvement, ipsilateral versus bilateral, and whether you can have a conversation with surgeon and pathologist or not. Because sometimes you find reports where you don't, after post-operative therapy, you don't really know there is written 2 node positive from level 2 to level 5. You don't know it's level 2, it's level 3, it's level 4 or what. So what we are doing is that in oral cavity and oropharynx, if it's a node negative disease, we go ahead with thyroid sparing. We don't do thyroid optimization. But if it's a node positive disease, if the node is positive at level 1 and level 2, thyroid sparing versus thyroid optimization depending upon your contour, your clinical knowledge and your examination. If it's a thyroid level 3 and level 4 node, we don't do any kind of optimization, we just try to treat the disease. Similarly, not similarly, but very differently from larynx and hypopharynx, again, node negative, thyroid sparing you can do, but if it's node positive disease, we try to see what is the distance of the particular node from the thyroid gland. If it's more than 2 cm from the thyroid gland, you can think of sparing versus optimization. If it's less than 2 cm from the thyroid, do thyroid optimization. If it's less than 1 cm, we don't even try to do any kind of optimization, we try to cover the disease first. Based on CTV, there should be no change in high-risk PTV at any cost. Low-risk PTV should always be cropped because most of the time we give low-risk PTV to a dose of around 50 to 54 gray. And in literature, elective nodal irradiation or low risk is supposed to get somewhere from 45 to 54 gray. So even if you are getting around 47, 48 gray near to the thyroid region, I think that should be enough if you are treating it electively. What is the contouring and planning we are doing? So we delineate thyroid as a separate OR and planning CT, mean dose constraint somewhere between 25 to 40 gray and volume based constraint be 30 to be 40 gray. Now how we give this, it's a bit individualized, whether you are taking unilaterally, bilaterally, thyroid is coming in the region of PTV, intermediate risk or low risk, and look for optimal coverage PTV obviously. These are the recommended data that I have shown that what should be the thyroid dose. We try to stick somewhere here. V35 less than 55%. So we try to stick somewhere around V30, V40, V35 less than 50%. So what are the techniques? We all know it can be IMRT, VMAT, proton delivery, collimeter and jar adjustment. These are the planning methods that you can do. Our physicists do this job very well and they try to see what can be done. Monitoring post-natal test and serum, obviously T3, T4 and TSH. Initially we do it at 6 monthly, 12 monthly and then every year if after that. At Vedanta Institute, currently we are following around 30 patients prospectively. Most of them are males, around 24 patients are male, most of them are post-op. 9 patients have received NACT. Till now, only 3 patients have shown mild derangement in thyroid function test. Duration, since the duration is only less than 1 year, so we are not publishing the full data. Because, like I said, if we do the thyroid specific thyroid sparing, definitely we will receive less dose. But whether that less dose is actually converting, we are converting them into a clinical outcome,